Good evening, everyone. Welcome to the Evenings with Genetics on the impact of COVID-19 on children with rare disorders. I am Susan Fernbach, and I'm the director of this series, and it's sponsored by the Department of Molecular and Human Genetics at Baylor College of Medicine and Texas Children's Hospital. And this is our first time to play music prior to the webinar, so you're welcome to submit suggestions. We're open to all of them. We are thrilled that you're joining us tonight. For interpretation to Spanish, you're welcome to use the interpretation button at the bottom of your screen, and simultaneous interpretation is being provided by Ms. Mercedes Alejandro. And please write your questions in the Q&A box at the bottom of your screen, and we're going to answer as many questions as possible after we hear from the speakers. And we really have a great webinar planned tonight. I am so excited to have a medical geneticist and an infectious disease specialist and a parent specialist. And so I will introduce our first speaker and we will get going. Dr. Mike Wangler is a medical geneticist at Texas Children's Hospital and is an assistant professor for the Department of Molecular and Human Genetics at Baylor College of Medicine in Houston, Texas. He received his medical degree and his training in pediatric and clinical genetics at Baylor. Dr. Wangler is interested in improving understanding and treatments of rare inherited disease. And his laboratory is involved in two major efforts looking at model organisms as well as Mendelian disorders of the peroxisome. And in doing so, he's hoping to gain insight into the general principles of human health. Please welcome Dr. Wangler, and I will introduce the other speakers as they come up. So warm welcome to you, Dr. Wangler.
Thank you so much. Thank you, Susan. This is always great fun to do. So it's going to be great to talk to you about the impact of the COVID-19 pandemic, specifically on the population of patients that I've been caring for, children with rare disease. So the outbreak of the SARS-CoV-2 virus that led to the COVID-19 pandemic has had a very complex impact on patients who had pre-existing rare disease. So families that were already facing the challenge of having a rare genetic disorder now faced many challenges and questions from the pandemic. And so in the seminar, I think myself, Dr. Healy, and Katie Sakura from the Global Foundation for Peroxisomal Disorders hope to inform you with discussions that will range from genetics, infectious disease, and rare disease family and advocacy issues. So as a geneticist, I'm sort of going to take you through the way that I suppose a geneticist could think about a pandemic. So first, we're going to start out with basics. We're going to talk about DNA and RNA, and there's a reason why that'll be useful. And then we'll go into the genetics of the SARS-CoV-2 virus itself, and then track into the genetics of us, the human host, which includes genetic mutations for rare diseases. And then we'll talk about how rare disease and the pandemic has impacted families. So as a geneticist, I always find it useful to think about how the flow of our genetic information works. So we can call this the central dogma if we think about molecular biology, and that is that DNA makes RNA, makes protein. So our genome is the DNA, which is packaged in chromosomes contained within the nucleus of our cell. And this is a very stable, high fidelity replication molecule that's the basis of heredity. And it's going to be the basis of what we think of as sort of the host genome in the pandemic. RNA, this is more like temporary messages that are sent from the DNA out into the cell to provide instruction. And then the protein, that's what does all the work. So that's all the structural components of the cell, all the chemistry, even the way that the lipids and the carbohydrates move in the cell is controlled by enzymes, which are proteins. So it's useful to think about this flow of information because in a RNA viral pandemic, the flow of genetic information is important for everything that we try to do, from monitoring infections to the vaccine technology. So the genome of the human host, we can think of that as that's 3 billion base pairs, and that's determining all the human traits that are at play. RNA is going to encompass the message from our genome, but it's also going to come into play when we talk about the SARS-CoV-2 viral genome itself, which is 30,000 base pairs of RNA. And then the mRNA vaccine technology, the new technology providing us with the vaccine, is also based on essentially providing our cells with RNA. And then some examples of key proteins would be things like antibodies that our bodies will make in response to infection or in response to the vaccine, and then viral proteins made by the virus that could be called antigens. And so thinking about the information flow can be useful when you sort of get into applications and think about examples. So going to go from there directly into the RNA genome of the SARS-CoV-2 virus. And so the way that the CoV-2 virus works is that the virion essentially packages the RNA genome, and then there's proteins like the spike protein that are on the outside forming the coating of the virus. So what's in the genome? So the genome, again, it's a long piece of RNA. It's 30,000 base pairs long. And it's going to encode all of the structural, accessory, and non-structural proteins that make the virus do the things that it can do. So what are the things that the virus does? So this kind of shows a map. I mean, we don't have to understand every step on this map to know that the virus is going to bind the cell. And then what it's doing is when it enters, it's releasing its RNA genome into our cell and actually hijacking the machinery that we use to make proteins from our own RNA. And then some key steps that the virus will do are replicate its own genome and then start to make the proteins to pack up and package new viral particles for release. So you can kind of think about the virus as doing something sort of like a Trojan horse. It's bringing foreign RNA into your cells, and it's hijacking the workings of your cells to make more and more virus. So, you know, this can be useful when we think about how the information flows, because you're dealing with the RNA genome, but you're also, of course, dealing with all the responses of the host, and that's where the genetics of the human host will come in. So from the beginning of the pandemic, I think many of us heard that there were specific risk factors for what would make someone more likely to have rare disease with COVID-19. So things like age, obesity, diabetes, heart disease, these were all risk factors. But what about genetic risk factors? So that is something that is being actively studied. And it's an area that is still under development. So this is showing some of the summary data across many, many studies. So what's done here is that you can see populations have been defined in terms of their rates of reported SARS-CoV-2 infection in green, in red, critically ill from COVID, and in yellow, hospitalized from COVID. And you can see maps across Europe, North America, Asia, and you can see that different populations have been studied with genetic markers, those populations having different rates of those COVID complications. And what's come out of all this body of work over a short time is that there are genetic determinants of severe disease, including things that may affect the immune system, something that Dr. Healy will talk about later, and other things that may determine the severity of other lung diseases have come up. So there's definitely things in the human host that can affect COVID infection. But what's been of more interest to me is these are markers that would go across many populations, but the population that I care for in my clinic is individuals with rare genetic mutations. So in our group, for instance, and across many groups here at Baylor, we may be very interested in diseases like peroxisomal disorders that Katie Sacker will talk to you about. And these are rare genetic diseases, and we're interested in understanding better molecular mechanisms of those kinds of disorders. And likewise, we may see patients that we don't have a genetic basis for their medical issues. And we may use tools like whole exome or whole genome sequencing to try to find that basis. So one study that we're very much involved in has been the Undiagnosed Diseases Network. This is a large network of centers that are aimed at trying to solve the most kind of difficult medical mysteries using technologies such as whole genome sequencing. And Baylor College of Medicine has been a very active site in this network. And there's a number of other studies that we have going on in our center, in addition to the UDN, the Gregor Initiative. We're starting a study called the Community Techsome, where we're target individuals who are unable to pay for genetic testing. There's epilepsy-focused, brain-focused, and precision medicine initiatives. And all of these have focuses a lot of our energy on rare and undiagnosed individuals. So what are the effects that we've sort of heard in our clinics and in our studies from these individuals about the past year and a half of the pandemic? So one of the common questions that has been difficult is, what about my rare disease? Does my rare disease put my child, or my child's rare disease, are they at a higher risk from COVID itself? So when you listen to the news, you may hear a statement like, well, the only people that really need to worry about COVID have pre-existing conditions, but then you have trouble figuring out what they mean by pre-existing conditions. This is something that's been interesting to me, is Prader-Willi syndrome, which is a rare genetic disorder, has actually had some research into the question of, are individuals with Prader-Willi syndrome at higher risk? And this is pretty interesting because one of the features of Prader-Willi syndrome includes obesity and diabetes, already things that we know are risk factors for severe COVID. There's an excellent patient group for Prader-Willi syndrome that has done a lot of amazing work using registry data to kind of try to understand how COVID itself has impacted children with Prader-Willi. And then in France, these researchers actually studied fairly rigorously whether a child with Prader-Willi, whether adults with Prader-Willi are at higher risk of severe disease from COVID-19. And what was interesting is that despite the risk factors that would come along with having this rare disease, they actually don't find evidence for it being a severe risk factor for COVID-19. And so I think this is interesting because it suggests that we may need to sort of take a targeted approach and understand each disease as we see it. But that's of course very challenging because the rare diseases being quite rare and the rates of COVID sometimes being, fluctuating in the community, it may be difficult to really capture that data properly. Another effort that we've been interested in is there's been groups like this group at UCSF who have actually looked at all of the viral proteins and tried to understand what are all the human proteins that interact with those viral proteins. And so what they're showing here is a map of all these different classes of human proteins that seem to get caught up in a viral infection with COVID-19. And according to this data set, there's 332 human proteins that you could consider being sort of candidates for COVID-19. And many of these are rare disease genes. So a lot of the laboratory work actually could help us understand whether we should think about certain genes as being higher risk for COVID. So, but I would say that amongst the questions about COVID itself from our families, there's a lot of other issues that you could call them unintended consequences or other downstream effects. So a lot of families have experienced reduced frequency and quality of medical care throughout the pandemic. There has been more utilization of telemedicine. We've had a lot more telemedicine visits for things like genetics. The change in education, the school closures, the quarantining of school children, this has had a big effect on a lot of our patients who are in the pediatric population. There's a big psychological impact on caregivers and families. Hearing from some families who said before the pandemic, we were pros at sort of being at home. Other people found it unusual. We found it normal. But we've had reduced access to the services that we usually get at our home. We've had reduced access to medical supplies. So a lot of these things have come into play to the effects that we've seen on our families. This was a study actually using survey data, but it went across many rare disease networks, and it showed just kind of in percent how many of individuals in these networks saw things like impact on mental health, challenge accessing medical care, using telemedicine, having to cancel medical appointments. And so it really is striking to see, numbers like 70, 80, 90% of the respondents having these types of issues during the pandemic. I wanted to mention a couple, real world kind of scientific studies that I think have been interesting. This one looked at a genetic rare disease called phenylketonuria, and the patients with PKU they require a special diet and regular lab tests for phenylalanine. And what was found in this study was actually that during the lockdown itself, this was in Italy, there over 500 patients, the actual levels across all the patients did not change. But when you look closer, what's interesting is there were individuals who had really good control of their disease before the pandemic. And those individuals maintained their control throughout the pandemic. But there were other individuals who were at higher risk, and they were having more trouble staying on their diet before the pandemic. And those individuals, the data drops out. So there's actually, they were less likely to monitor their levels at all. They didn't know where they were. And so this raises concern that even within certain rare diseases, you can have some groups of families that are doing quite well, but other groups who were struggling before are struggling even more. So just a few other considerations that I'll bring up that I think have been interesting questions to entertain. So one is, should families with rare disease, have more concern about infection with the virus than others? And, again, I would say we don't know enough about the specific rare conditions, but in general, we should look at age as a really important determinant. So it does seem like age is a key risk factor in considering these things. So some of the family groups who've been making a lot of progress in research on certain rare genetic disorders have had concerns like, are we seeing a shift away from rare disease, a reallocation? And is it more difficult now to do those rare disease studies, those trials that we need so much? And I would say, yes, there's shifts. There's all kinds of shifts in biomedical research right now, but there's also new opportunities using telemedicine, using other tools to make our research more efficient. And then finally, this has been an interesting question to think about, is that some individuals have brought up that they may be on enzyme replacement therapy, or there's individuals with rare disorders who are looking forward to the potential of gene therapy, maybe with certain viral delivery vectors. And the question is that going to interact with being infected by this virus or from the vaccine? And in general, the answer to this is that most of the gene therapy that's being proposed or currently considered is using viral vectors that are, distinct from the J&J or AstraZeneca vaccine. They have nothing to do with the Pfizer or the Moderna vaccine. So in general, it's not something to be concerned about. So I just want to go back again to the flow of information. So I think when we think about a problem like this, it's sort of what's in our genomes themselves. Then when we go down to the next level of sort of the RNA, it's how are our genomes handling the challenges that come at it, such as infection or the health challenges of the pandemic in general. And then when we come down to the protein, the actual events in our bodies, that's the response, and also the response of the rare disease community to the challenges. So that's all for my comments, but now the key piece that you didn't get any from me at all is the actual infection and immunity, and that's why we have Dr. Healy here. So I think Susan will introduce Dr. Healy.
Yes, and thank you, Dr. Wangler. That was awesome. I really have the distinct pleasure now of introducing our second speaker, Dr. Mary Healy. This really is a wonderful event to be able to have the expertise in the room. And so Dr. Mary Healy is a pediatric infectious disease specialist at Texas Children's Hospital and an associate professor of pediatrics at Baylor College of Medicine. She received her medical degree from the National University of Ireland and membership in the Royal College of Pediatrics and Child Health in the UK. And in 2000, she moved to Houston, where she completed fellowships at Baylor in pediatric infectious diseases and vaccinology and vaccine preventable diseases. Dr. Healy's research interests are focused on preventing infections in mothers and infants through maternal immunization and on improving vaccination rates in all age groups. Her work has been published and presented both nationally and internationally. So please welcome Dr. Mary Healy. Sorry.
Thank you. And thank you, Susan, for that very generous introduction. And it's a pleasure to be here this evening to talk to you all about the impact of COVID-19 on children with rare disorders. And I put a subtitle on my talk, Reasons for Hope, because I really think that since the beginning of this pandemic originally in December in 2019, but it was really February and March before it really hit us in the United States. I think that there are substantial reasons for hope that we will be able to get out of this and in a way have our lives back a little bit more to whatever our new normal is going to look like. First of all, just to disclose that I am an investigator on COVID-19 vaccine trials in both adults and in children. And over the course of the next 20 to 25 minutes, I'm going to try and give you a brief overview of our immune system. I'm going to talk a little bit about infection and COVID-19 disease burden as it applies to pediatrics. But I'm going to focus a lot of my talk on the vaccine options that we have to protect us against COVID-19 and how we address some of the myths and misinformation that are pertaining to that so that we can prevent what's preventable. Because really COVID-19, the disease, is in many ways preventable at this point in time. So the immune system has really been described as a police force that patrols and then when it needs to calls back up. And our immune system is divided into our innate immune system and our adaptive immune system, which work very closely together to keep us safe. And just to see how it keeps our entire body safe, you can see all these organ systems are involved in our immune system. So you have the bone marrow and the thymus In the bone marrow, we have stem cells which differentiate into individual blood cells. I'm going to focus especially here on the white blood cells, particularly lymphocytes, which are divided into B lymphocytes, which are the lymphocytes that make antibodies. They mature in the bone marrow, hence the word B, hence they're called B, and our T lymphocytes, which are involved in what we call cellular immunity, and they mature in the thymus. So obviously they're called T lymphocytes. And throughout our body, we have our lymph nodes, our glands and vessels, which are full of immune cells. And then our spleen, which filters, activates and increases the number of immune cells whenever is necessary. And last, but by no means least, let's think about our skin, which is a physical barrier against infection and thus has a very important role to play in our protection. Now, innate immunity is immunity, if you like, that's just there from the word go. So involved in our innate immunity, we have things like physical barriers. I mentioned our skin already. We have cilia, which line our respiratory tract, and if you like, wave and waft bacteria and other pathogens that cause disease away. And we have mucus, which contains some enzymes which can also destroy pathogens. We have chemical barriers, again, our skin, we have our mucus, and we have stomach acid, which can destroy a lot of our pathogens. And then not only do we have bacteria that can cause us harm, but we also have commensal bacteria that live in our body. And if you like, keep our body in a natural state of homeostasis where they're interacting well together. And then the final part of our innate immune system is what we call the non-specific cell responses. So these are cells which are within our body, which ingest pathogens and get rid of them very quickly. These are things like our neutrophils, which are the white blood cells in our blood, macrophages that congregate in our tissues, and they secrete messengers called cytokines that recruit other immune cells to the area and are actually responsible for the inflammation response. Then we have dendritic cells, which bridge between the innate and adaptive immune response, and a special type of white cell called natural killer cells, which contain viral infections, if you like, until the adaptive immune response is active. And then we have the adaptive immune response, and there are a variety of what we call antigen-presenting cells. The most important are probably the dendritic cells, which migrate to tissues wherever they're needed, ingest pathogens, and then signal other components of the immune system to activate. We have our T cells, our T lymphocytes that we've talked about already. You have things like our helper T cells that oversee the cytokine response, our cytotoxic T cells that directly kill cells that are infected by viruses, and then our regulatory T cells that signal either to increase or decrease activity of different components of the immune system at different stages in infections. We also have B cells, and B cells, as we know, are in the mature in the bone marrow, and they increase in number quickly and produce antibodies that are specific for whatever pathogen, whatever invading organism is attacking the body. They bind to it and they neutralize it. And then once the acute phase is over, you have memory B and T cells, which are ready to be activated in the future if someone is reinfected. So let's move on now and talk a little bit about COVID-19 infection and COVID-19 disease burden. So like other coronaviruses, the SARS-CoV-2 virus, which causes the disease COVID-19, has spike proteins on the surface. And this spike protein is very important because it's this part of the virus that binds to receptors which are on our cell walls and allow the virus infect the body. At that stage, the body's adaptive immune response springs into action. And it's actually likely that in some individuals, maybe those who have a specific genetic predisposition, that some of the complications of COVID-19 are likely due to the intensity of that immune response, which, as with everything, may well be genetically determined. In terms of the symptoms of COVID-19, as we all know, there's a wide spectrum of illness. Fever is prominent. There can be respiratory symptoms. There can be GI disturbance, muscle and joint pain, headaches, and characteristically somewhat a loss of taste and smell. But we all know that not everyone gets all these symptoms and not everyone actually suffers from them in the same way. And we do know that certain factors make someone more vulnerable to complications with COVID-19. And some of these are factors in children who may have rare genetic disorders. There may be lung disease, liver disease, obesity, neurologic conditions, heart disease, kidney disease, diabetes, and hematologic or immune function problems. However, somewhat paradoxically, some of the disease is not as severe in some individuals as you might have expected, as Dr. Wangler has shown there with the Prader-Willi example. But we know that once you get infected with COVID, then children are prey to a number of post-infectious syndromes, even if they survive their initial disease. There's the multi-system inflammatory syndrome of children, which is basically a hyperinflammatory syndrome. It occurs, we think, in about 1 in 3,200 children who are infected with COVID-19. But 60 to 70% of those need ICU care and 1 to 2% die. And even if it's not that severe, there have been studies from the UK showing that 7 to 8% of children with COVID-19 have continued symptoms for more than 12 weeks since their diagnosis. And the most common symptoms are things that are fatigue, headache, insomnia, difficulties concentrating, and coughing and muscle and joint pain, which, as you can imagine, can be very debilitating and, not surprisingly, have considerable impact on an individual's quality of life. And again, when we're talking about quality of life and some of the other issues in the pandemic, this is particularly important for children who may have their physical activity limited, who may have mental health challenges, and have even more difficulty accessing school attendance or their participation in support groups. But one of the great successes has been the development of effective vaccines against COVID-19. So let's talk a little bit about this, because a lot of the time people feel that it's somehow better to have natural versus vaccine-induced immunity, not only against COVID-19, but against other infections. So vaccine-induced immunity against COVID-19 is really high. It is way better than any of us working in the field expected when we started these trials in the summer of 2020. But it's not 100%. Nothing ever is. It's also complicated by the fact that as of yet, we don't know what the actual protective antibody level is. So we don't know what that sweet spot is that we can say to someone, if you have this amount of antibodies, you don't have to worry, you're not going to get infected. We do know that individuals who have natural infection have an extremely wide range in antibody titers. That unfortunately correlates with severity of illness. So it kind of is the saying that what doesn't kill you may make you stronger, but it may cause tremendous damage while it's doing that. So those antibodies are really very hard won. And vaccination typically leads to a more consistent and a higher titer initial antibody response. Now, we also know that for certain populations, particularly the elderly and those with immune compromise, protection may be decreased following both vaccination and infection. Increasingly, we're learning that the level of protection may vary as new viral variants come about. But we know that vaccination after infection significantly enhances protection and further reduces the risk of reinfection, which is why it's recommended. So I'm going to focus a little more prominently on the messenger RNA vaccines for two reasons. Firstly, because, well, for one main reason, firstly, because they're the only vaccine that's currently licensed in the pediatric and adolescent age group at this time, because the adenovirus vector vaccine made by Johnson is only authorized for age 18 and above. So as you've already heard, messenger RNA is genetic material that essentially teaches your body how to make proteins. So what's in the mRNA vaccines? So those vaccines are made of mRNA that specifically codes for the spike protein from the SARS-CoV-2 virus. That's wrapped in a coating that makes the delivery easy, and it keeps the body from damaging it. And essentially, this is injected into a muscle cell. And what happens is the mRNA, which never enters the nucleus of the cell, so can't be combined with DNA or incorporated into DNA, actually tricks the cell into making the spike protein. And then the body, immediately recognizing that the spike protein is something that shouldn't be there, arms its police force and mounts an immune response using all the factors of the immune system that we've talked about already. So really, if you're a vaccinologist, you think this is very, very cool. And we also know that these vaccines are incredibly effective. I mean, when we began these trials, we would have been delighted with an efficacy of 60 to 70%. Instead, we got ones of 94 to 95% efficacy in preventing symptomatic and severe illness. It also reduces mild and even asymptomatic disease. There are emerging data that because they can do that, they're reducing transmission. And we know that that efficacy persists at least through about 6 months, although boosters may be needed and will be needed. And we also know that even though variants have emerged, these vaccines have remained effective against severe and fatal infection that's been caused by those variants. Now, the other vaccines that are in development, first of all, we have the adenovirus vector vaccine, which is the J&J vaccine. That actually removes 2 genes that allow the adenovirus to replicate and replaces them with a gene encoding for the SARS-CoV-2 spike protein. And that's that mode of vaccine. And then you have what are called protein subunit vaccines, which are still in clinical trials. There's vaccines made by Novavax and Sanofi Pasteur that are in development there. So now I'm going to move on and talk a little bit about the myths and the misinformation that we get about this whole vaccination development process and release. So let's look first of all at the road to vaccine licensure. And traditionally, this has been a long road. It starts with an investigational new drug application, and then the candidate, and this is after animal studies have been done, goes into human studies, which are phase 1, phase 2, and phase 3 that we'll talk about in a little while. And only after those results are available does it go to the FDA. The FDA has an independent committee review all the data, and if it okays this, Then it goes to the Advisory Committee on Immunization Practices of the CDC, another independent committee that considers the data, votes on the recommendations, and only when the CDC publishes in the Mortality and Morbidity Weekly Report does it become a recommendation. So in normal clinical trials, in phase 1, these trials are in less than 100 people. They normally take 12 to 18 months, and they focus on finding the safety and tolerability of a product. Then they go on to phase 2 studies, which can take up to 2 years. That determines the best dose and schedule for the particular product, looks at the immune response in more detail, and that can occur in about thousands of people. And it's only after that that we move on to phase 3 studies, which normally last 2 or more years and answer the question, does the vaccine prevent infections or reduce the severity of disease? And that normally entails thousands of people, including some who are at specific risk of infection. So what happened with COVID-19 was that all these phases, if you like, the timelines became accelerated and overlapped. They were not skipped. And what happened was that as soon as we had good data that a phase 1 or phase 2 product was safe, then we started the next phase of the study, while the phase 1 and 2 studies continued. So what it meant is that no step was skipped, and that the phases continued in parallel with each other, and the studies are still ongoing. What happened in terms of licensure is exactly the same process, only again, it happened at a faster rate because of the extreme emergency for the entire world. No steps, however, were missed. And just to put it in context, how we were able to speed this up, normally ACIP meet 3 times a year. They've met 10 times this year already, because as soon as data become available on an individual COVID-19 vaccine, the FDA meet and then the ACIP meet to make recommendations. And we are continuing to do safety assessments. It's being done through the VSafe program, which any of you who've been vaccinated know that you get the app on your phone and you get an alarm every week or every month, depending on where you're in the process. We have other processes that are in place, such as the Vaccine Adverse Event Reporting System, which is a voluntary reporting system and can give us a crude indication if there's a reason to be worried, which can then be investigated by a more sophisticated process, such as the Vaccine Safety Data Link, which is a linked database used for population-based surveillance. But there still, unfortunately, are a lot of myths. So I'm just going to tackle a few in the next few minutes. So variants are not caused by COVID-19 vaccines. New variants of a virus happen because it's natural for a coronavirus to constantly change through a natural process of mutation. And even before we had COVID-19 vaccines, there were already several variants of the original SARS-CoV-2 virus. On the contrary, COVID-19 vaccines can help prevent new variants from emerging, because the less of the virus there's circulating in the community, the less chance it has to mutate. COVID-19 vaccines do not contain microchips or any ingredients that could make you magnetic. And that's all I can say about that. And COVID-19 vaccines cannot give you the infection, because none of the vaccines contain live virus. So they cannot cause you to shed the virus. They cannot cause you to get a positive test for COVID-19 or actually give you the illness. As we've talked about as well, COVID-19 vaccines cannot alter your DNA. They don't change or interact with your DNA in any way. the genetic material in mRNA or the adenovirus vector vaccines never enter the nucleus of the cell, which is where our DNA resides, so it cannot be incorporated there. And this is one that has come to light, especially as COVID-19 vaccines have been recommended for pregnant women. But COVID-19 vaccines do not and cannot affect your fertility. As a matter of fact, they're strongly recommended for anyone who's planning to become or who's currently pregnant due to the increased risk of severe COVID-19 in pregnancy, for which there's definite evidence that this is a high-risk situation. Despite this, it's very easy to recognize why there may be a decision continuum when you're deciding whether or not to get vaccinated. And if you look at the decision continuum, you can see that the vast majority of people are in the middle, like to ask questions, like to get some more information. Very few people are strongly refusing vaccines and really entrenched in that viewpoint. A lot of people may have questions, and if you have questions, rather than going to social media or listening to stuff that may be unfiltered, really your healthcare provider is the best resource, because after all, you trust them to take care of you, you trust them to take care of your family. And then I'm going to finish just a little bit, just by talking a little bit philosophically, because I'm very focused on preventing the preventable. And to my mind, COVID-19 is preventable. And I was drawn by this quote, which I believe originally is attributed to Stalin, but which I found in this nice JAMA article where they were talking about communicating risk. And it's the death of one man is a tragedy, the death of millions is a statistic. And to a certain extent, that resonates with me when I think of COVID-19, because it's kind of, if you like, being dehumanized. When we think that 5 million individuals at least globally have died of this disease, and over 750,000 in the United States, it's hard for our minds to get around that larger figure. So what we need to get is go back and think, well, but every single one of those was a person with a family, with loved ones, and who suffered, and whose family and loved ones are suffering, and need to think back on how can we prevent that happening? And more importantly, how can we protect those who are unable to be vaccinated or in whom the vaccines don't work? Well, there's some ways that we can do this. We can certainly ensure that everyone who's vaccine eligible is vaccinated against COVID-19. This is a public health strategy called Cocooning, essentially meaning that if you surround yourself with people who are protected, nobody can give you the disease. And, you know, wearing a mask really is at this stage a symbol, I think, of caring. So the CDC recommend that everyone in your family, even those who are vaccinated, wear a mask indoors in public if you're in areas of substantial or high transmission. And most of the time in this pandemic, unfortunately, Texas is one of those states. And then unvaccinated family members who are more than 2 years of age should wear a mask in all indoor public settings. And again, I go back to, we need to prevent what's preventable, and COVID-19 is preventable at this stage. And just to put it in a historical context, I think that getting vaccinated is really putting yourself on the right side of history. And this has always struck me as a sad situation. So Benjamin Franklin, it may not be known that when the smallpox vaccine initially was being recommended, he was one of the biggest vaccine skeptics and used his family newspaper very strongly to advocate against vaccination until he lost one of his children. And this has always struck me as a very poignant quote. I lost one of my sons, a fine boy of 4 years old, by the smallpox, taken the common way, in other words, naturally. I long regretted bitterly, and still regret, that I had not given it to him by inoculation. And I think as a parent, that really resonates with me. There's so much that we can do nothing about. Why not prevent what's preventable? So thank you very much. And I look forward to hearing our next speaker.
Thank you so much, Dr. Healy. That was fantastic. Our third speaker is Miss Katie Sakra, and she's the parent of an adult son with a rare disease and the director of family programs for the Global Foundation for Paroxysmal Disorders. She will share her personal experience as well as her experiences supporting families during the pandemic. So please welcome Katie Sakra.
Thank you so much. And I'm hoping I'm going to get through this without coughing too much, all this talk of illness, and I am very ill, so I apologize. The impact of COVID, though, is such a loaded question. I think Dr. Wangler spoke to the unintended consequences. I had wrote secondary impacts, whatever you want to call it. I think that COVID itself is one thing, but then those unintended consequences, that is what's really impacting families, in my opinion. In my own situation, I have a 21-year-old who is living with a paroxysmal disorder, and his world came to a complete stop, and there was no way to explain it to him. The impact we felt immediately was the lack of services, but I was worried about his health. What I was not prepared for was the depression, the confusion, the anger. So the mental emotional impact was what hit first, and I was not prepared for that. He actually began sleeping quite a bit. He had increased behaviors. He has a board in his room where he communicates with object cards. And I found him one day with his forehead against it and just rubbing with his hands. It was his way of communicating what is happening, what's coming next. And I had no way to explain it to him. Obviously, the next impact was his physical. The loss of services, not being able to go to school, not being active, not receiving physical therapy, occupational therapy, speech therapy, orientation and mobility services. He has all these different teachers for the visually impaired. He has a deafblind intervener that works with him. He goes out in the community. To make matters worse, it was a transition year for us. So my son was actually supposed to graduate, and we were transitioning him doing work-based learning out in the community. The worst time you could be out in the community. A pandemic hit, and we were supposed to be transitioning him to be able to have adult services, be out in the community, go to the store, go to the car wash. These are all things we were so excited and have worked for years to make happen. And it all just came to a complete stop. And there was no way for him to understand this. I didn't take him to outpatient services because I was afraid. Many of the high risk factors that Dr. Healy was showing on her slides, my son has, because his disease is a multi-system disease. It impacts every system. And so I was terrified, rightly so. I'm still terrified. At one point, I realized how weak he was getting. It was only 4 months into the pandemic. And I noticed physical changes in his lower extremities. So I talked to his physical therapist, and we worked out a way to have him receive physical therapy outside with her masked. I live in the South. I think everyone listening maybe be in Texas and understand how hot it gets. So his physical therapist asked me, she said, Katie, he's getting really bad. I need to treat him, and it's too hot outside. We can't stop. And so I agreed and said, okay. And she masked up and put a gown on, and she took him inside. The first time I agreed to let him go in and do this, she tested positive with COVID a week later. So as I'm sure you all can imagine, I was scared again and said, I can't do this. So families like myself were really faced with this challenge of quality of life for our children, because while we were trying to keep them safe, we were watching their health deteriorate, because I know a lot insurance companies do not like the term maintaining. If you know anything about therapy services, they do not like the word maintain, but that's what a lot of our children need. We have to have these therapy services to maintain. We're in this uphill battle, and all of a sudden we didn't have them. We had families that were pulling out equipment, walkers that they had worked so hard, their children for years were in therapy and be able to stop using these devices. And they had to pull this equipment back out of storage and watch their children use it because they weren't getting the therapy services that they needed. Educationally, a lot of our children with paroxysmal disorders have hearing loss and vision loss. So the virtual component was extremely challenging. Add to that the special education law wasn't clear on how to handle this pandemic at all. So in our personal case, my son was aging out and was supposed to graduate. And yet there was nothing to be able to say, how do we do this? Do we continue services? I had a special education attorney who didn't have any answers to this either. We were in unknown territory, and so many other families across the country are too. My child, like many other, have sensory issues and can't wear a mask. Until recently, a lot of the children are younger than my son and couldn't even receive the vaccine. I wanted to share a little bit too about other families, not just my own. And so in talking with other families, because I oversee all of the family support for the Global Foundation for Paroxysmal Disorders. And I have really been walking this with so many families and listening to them and hearing what their struggles have been. And so here are just a few things I wanted to share with everyone tonight. One person said, our biggest issue on the medical side is the fear of taking our son anywhere, including appointments. We're actually refrained from going to appointments in big buildings and hospitals. Another one said, as far as everyday life has been, the stress on our kids being home, the disruption in their schedule, the regressions are just heartbreaking. Another, my biggest issue as a caregiver is the fear of traveling for medical appointments. My child is a year overdue, and this was written several months ago, for important monitoring and testing, but the children's hospital is in the middle of a hot zone and 4 hours away, and typically requires staying 2 to 3 nights. And I think that a lot of us in the rare disease community feel this because we have to go to these specialty centers. So there's a lot of travel involved. Feeling unsupported and left out of the conversation. Another parent shared, my biggest issue as a caregiver is watching my daughter be completely left out of the conversation of support. The disability community and their needs have been completely ignored, like they don't exist, and nothing has been put in place to support individuals with disabilities or their families. As a caregiver and a mom, to know my child isn't on anyone's agenda to help is infuriatingly insulting. The change to hospital policies and visitors has really been an impact on families in the rare disease community as well. One of our biggest struggles through the pandemic, one parent shared with me, was only having one caregiver allowed in a 24-hour cycle at their hospital system. They had to stay in the hospital for several days with minimal outside interaction. It was difficult for an emotional support, not having that person there, difficult decisions being made. And it's not just inpatient. There's also the struggle where we had several families who were going to outpatient appointments and procedures, and were told only one parent could go. One mom shared with me that she would stress herself out for days before one of her daughter's 6 hours infusions. She would almost make herself sick, knowing that she had to tackle the appointment alone. Her anxiety would be so high herself, and yet she was needing to calm her daughter and be able to listen to the doctor as he answered important questions. Caregivers of medically fragile children were given no support during this pandemic from the medical facilities we have to rely on the care of our children. That's a direct quote from one of our families. And for some of us, I think something that was really jarring to many professionals that I've spoken with, I include myself in this conversation, is being a parent to an adult with cognitive disabilities and hearing about hospital systems not allowing the parents to be in the hospital, and knowing that we were having to face the decision that if our children got sick, we would keep them home and risk them dying than letting them go into a hospital system by themselves and dying alone. That is an unintended consequence that many families have faced. The isolation, we had one parent share, it felt like we were put in timeout on our already deserted island because the interventions and therapies being stopped. We had limited home service and a fear of going out into the world. That quote actually was shared by a really good friend of mine, Dr. Mosimi Bose. She wrote an article on Rare Disease Day this past year. And I'm actually going to put a copy of that link into the chat box. I know it's an old article, but I really encourage you to read it because, you know, she talks about our families already having these limited interactions to reduce infection risk prior to the pandemic. And then she discusses how the community surrounding a family affected by rare disease is so crucial to supporting its overall quality of life. And so she wrote even in her article about her own son was dying of a paroxysmal disorder. And she wrote, "In the hardest moment of my life, that loving support contributed immensely to my healing. Without it, families facing similar circumstances during the pandemic will be alone during their most difficult times. The effects of these traumatic experiences can be long lasting," end quote. And so for me, I know we're talking about the impact on rare disease on children, rare disease, but it's really a big family approach for me because it has impacted the children, it's impacting the families. And overall, if it's impacting the family's quality of life, it's going to impact the child and their health and their quality of life. And I don't want to end this on a negative note. So I did want to share a few positives. And that is, yes, I heard, I think as Dr. Wangler shared, maybe about the telehealth. That has been something that has increased and been really valuable to so many families, I think, because we were already taking off and traveling to these specialty centers. Access to virtual events even, and being able to listen in. A lot of different rare disease events are becoming much more accessible. There's an increased awareness of the caregiver and family support needs, including the priority of vaccine access during a pandemic. I actually became part of a working collaborative to help advocate for vaccine access for caregivers, because the children are usually going to be last being able to receive the vaccine. And so the caregivers are really a line of defense for our children. There's also an increase in empathy for what many of us go through when we're not in a pandemic. When the pandemic hit and everybody had to all of a sudden be isolated, it was a little bit of welcome to our world. And then just look at the conversation that we're having right now and how important it is. And thank you so much for asking me to be a part of this and for just having this conversation, because it's so important to us families to know that you're thinking about all of these things.
Thank you.
Thank you so much, Ms. Sakura. That was very powerful. And wow, I think that, you know, everyone has certainly begun to understand some of these things, but you really put it into a very strong format with all of the discussion that you've had with other families, as well as your own experience. And I'd like to open it up to some of the questions we have here in the chat now. And I guess we could start with the first one. Is there a particular blood type that is less likely to get COVID?
Yeah, I mean, Dr. Healy can correct me, but I think they've now done a meta-analysis of all the different. I mean, so it's not quite genetic markers; it's actually the blood type markers. And the idea is that there does seem to be a higher, in most of the studies, it seems like the A type, you have some increase in the likelihood of getting, of turning positive. The severity of disease, I think it varies study to study. Some of the studies, A group could have more severe disease, but then other studies maybe don't reproduce that result. There's a kind of a hypothesis, I don't know if it's been looked at in detail, which is that if you make antibodies against A, which would be anyone who has an O blood type or a B blood type, that somehow helps protect, that antibody has some kind of marginal protection against getting infected with COVID. Maybe Dr. Healy should have answered that though.
You know, well, I think I would have answered it by saying, you know, we really just don't know a whole lot. So yes, while there's evidence, you know, I think it's unlikely that, as in lots of infections, that it will be a single factor. It's more likely that it's going to be a complex interaction between many genetic markers, and somehow whatever is happening with this, blood group A seems to be implicated, but that's not the whole story. And unfortunately, I think because we're in a pandemic, and because this is a global pandemic, the likes of which I never thought I would live through, you know, our expectations of how quickly we should have these answers were accelerated as well. But if you look at other infections, for example, meningococcal infection, which causes meningitis, people have been studying this for decades to try and figure out why some people can carry the bacteria harmlessly in the back of their throat, and others can get the infection and be dead in hours. And it's still not sorted out. So I think that you know, these answers will come, but they won't come quickly. And I also want to thank Ms. Sacra for really, in a nutshell, just putting it in a like almost wrapping it up as a package, and being able to describe not only the effects of the pandemic on specific families, but I think on us all as a whole. And I really wish that we could have other people listen to you, and, you know, because it's so powerful. I'm not often speechless, but I kind of am now.
And I certainly was as well. So I agree completely. I would love to go to the next question too. Is the vaccine itself, can it impact kids with rare disorder and diagnosis? I mean, being more at risk to get side effects such as myocarditis. And thanks for this wonderful meeting.
Okay, so again, there's a lot that we don't know. However, in as much as we know right now, the risk of natural COVID is far greater than the risks of any of the side effects that have been seen with the vaccines. So let's talk about the myocarditis and put that a little bit into context. These were huge studies for the mRNA vaccines. 40,000 people were looked at. This was not something that was seen in any of the studies. However, when the vaccines were used in millions of people, and they've been used in millions of people worldwide, there is a slightly higher than background incidence of myocarditis. Again, to put that in a different context, it seems to be predominantly in young males between the ages of 16 to 30, at least for right now. That doesn't mean that other age groups don't get it, or that females don't get it. It just means that it's rarer in those populations. And let's talk a little bit about the severity of that myocarditis. So it seems to occur after the second dose of the vaccine and to cause transient myocarditis in the overwhelming majority of people, which is self-limited and from which there's full recovery. And if you contrast that with natural COVID infection, the story is unfortunately very, very different. And very often the myocarditis from natural COVID is one of the factors that contributes to severe and ongoing illness and to death. So I think, you know, while we don't have all the answers that we have so far are very firmly in favor of the benefits of vaccination rather than not doing so. Although this, of course, will continue to be studied. And I wish we knew more, but only time will tell us that.
Thank you. And there is a comment from another family that we suffered from extreme isolation as well. Even though we spend lots of time alone, it was extremely hard to isolate ourselves even more with no help or therapy. So I think Ms. Sakura has really encapsulated this very well in her comments of the struggle of that. I would like to ask a question too about the cocooning now that we're approaching Thanksgiving, and that for families where all of the caregivers and family members getting together, you would recommend that they would be vaccinated at least 2 weeks in advance of the time that they're all gathering, I guess.
Yeah, absolutely. I mean, obviously, the most effective protection is direct protection, which is that someone is vaccinated themselves. But there are children who will not be vaccinated in time, won't have completed the 2 series, and have had that 2 weeks afterwards to mount their antibody response. And their children or individuals for whom the vaccine is not recommended yet, because it's still being studied. And there are individuals in whom the vaccine doesn't work because nothing is 100%. And by that, an indirect protection by cocooning is certainly, way better than nothing. We're lucky in many ways that we live in Texas, because, the weather tends to get nice at this time of year. It's one of the advantages, generally in years where we don't have an ice storm, of living here between the months of October and April, in that it's very nice weather to actually eat outside. And we know, for example, that eating outside or activities outside in general are less risky in terms of transmissibility of COVID-19 than indoor activities, especially where the ventilation may not be optimal. So, there's a certain element that all you can do is your best, but it seems, to me at least, but I would probably say this, that, recommending that everyone gets vaccinated who's around a vulnerable family member is not that much of an ask. I personally didn't leave grandparents visit my daughter until they'd had their flu shot, and they'd never had a flu shot before. I won, so.
Congratulations. Yeah, that's great. Are there other questions? I see. Okay, I'm sorry. So, and how long will it take the vaccine booster to be effective?
So, any time you get a vaccine, it normally takes, the dogma is 10 to 14 days to mount an antibody response. Now, how quickly a response will be mounted after a booster, where you already have those memory cells that are ready and primed to be activated, we're still doing those studies. So, for example, all the Moderna, Pfizer, all those vaccine studies are now pivoting to boost all their participants and do some blood tests to actually answer some of those questions. But I think if you were to be purist about it, I would assume that it will take 10 to 14 days to be safe, although your immune response is improving daily from the day you get your shot.
Excellent. And there's a question, my son is living with hypotonia, ataxia, and delayed development syndrome, is at high risk for febrile seizures. Thankfully, he recently received his first Cocos vaccine dose with no issues, and we look forward to receiving his second dose shortly. Receiving the vaccine should theoretically reduce his risk of developing coronavirus-induced febrile seizures, correct?
Yes, because it should prevent the coronavirus infection, or at the very least symptomatic coronavirus disease, which would reduce his chances of having fever. However, I would caution that second dose tends to be a little bit harder than the first dose. So you may need to be ready, with Tylenol or Motrin or whatever he takes, and the slightest hint of him, if he has a propensity to get febrile seizures, that as soon as you begin to feel that body temperature rising, to give him a dose post the vaccine to prevent that happening, because fever has been seen, especially after dose 2.
Okay. Great. I don't think we have any other questions. I really would like to thank each of the speakers. You have done a marvelous job. I'm so excited that we were able to offer this webinar. And because of the pandemic, it is on Zoom, and so we can reach out across distance. So I thank you sincerely for this outstanding webinar. And thank you all for the excellent questions.
Yeah, thank you. Thanks so much.
Thank you.
Thank you, Dr.
Thank
Certainly.
you. It's a pleasure.
Happy
Thank you.
Thanksgiving, everyone.
Thanks,
Yes.
Susan.
Thank you.
Yeah.
Bye-bye.
Bye-bye.
Happy Thanksgiving. Thank you.